Hey everyone, welcome back to part 2 of our Step 2 Infectious Disease Pneumonia quiz. This is the quiz that can be found on our website, buzzwordsmed.com, and it's based off our podcast, Buzzwords, the Med School Drinking Game. So, without further ado, let's start where we left off. So, the next question. An 8-week-old newborn female brought in by mother for staccato cough. Treatment is initiated. What is the classic risk in this patient population with the given treatment regimen? So this question is multiple levels deep, and let's see what the answer choices are. Hyperplasia of GI tissue, inhibit surfactant production, none of the above, and stained teeth. So one of these is a risk factor with the given treatment regimen. And we don't really know what the treatment regimen is, but we do have some hints as to what the kiddo's coming in with. So this is probably a 3 or 4 level deep question. So let's start off at the beginning. You have an 8-week-old newborn female. So a young kiddo with a staccato cough. So that makes me think of a couple things in an 8-week-old female that was just born. What it really is pointing to is probably, to me at least, chlamydia pneumonia to be specific. So that's what I would initially think with a staccato cough in such a young one. So treatment is initiated, so then you have to know, how do you treat chlamydia pneumonia? The answer would be a macrolide, oral macrolide. And then what is the risk associated with a macrolide? So then you have to just think about all the things that, like for example, azithromycin, clarithromycin, what can these cause? And the answer here is actually hyperplasia of GI tissue, and it's getting at pyloric stenosis. So those kiddos that take pyloric stenosis can lead to hyperplasia of GI tissue. Those kiddos taking macrolides can get pyloric stenosis. There's that known association. So that's the correct answer here. If we go to inhibit surfactant production, remember that's what happens when kiddos create insulin in light of all this sugar that they get from a mother with diabetes. So that can inhibit surfactant production, so that would be insulin. And then stained teeth, those are tetracyclines. All right, so next question. A 28-year-old National Guard based in Arizona presents with fever, cough, and joint pain. Noticeably skin exam, significant for red, tender nodules. Which infection is of most concern? So, you have an otherwise seemingly healthy guy in Arizona. They're probably telling you it's Arizona for a reason. Comes in with kind of non-specific symptoms and some nodules, which they make sure to emphasize. So, which infection is most concerning? So, the first answer choice is nocardia. Nocardia, I don't know if you remember the sketchy episode where it's no cards for old men or something like that. So I think of immunocompromised. I think of CNS lesions as well. So nothing from here stands out in regards to nocardia. Chlamydia psittaci, Psittaci. This is the chlamydia etiology, This is the chlamydia that is often found in those handling birds. It causes pneumonia because we don't have any good history regarding bird care. Maybe he's in the Falcon Division in the National Guard, but because we don't know that, we cannot reliably choose chlamydia at this point. Coccidioides is the third answer choice, which is a pretty good answer choice given that this gentleman is in Arizona where it's endemic. Arizona, California should be hints for coccidioides. And also red tender nodules on the extremities, which make you think of what? That's right, erythema nodosum. So those are all pointing towards coccidioides. I can see why that's an answer choice here. And then the fourth answer choice is Legionella. Theoretically, this guy could be living in the barracks where there's central cooling, and that could be the hint for Legionella. I think the skin findings point more towards the fungal infection rather than Legionella. So it's not the worst answer choice, but I think coccidioides is the stronger one, so that was the one I would pick. If you go to our images here, you'll find actually a beautiful picture here of erythema nodosum, classic in some of these fungal infections. All right, the next question. Which regimen below is first line for community-acquired pneumonia? So, is it clindamycin, cefepime, ceftriaxone and doxycycline, or vancomycin and piperacillin, tazobactam, or pip/tazo? So, community-acquired pneumonia, you got to think about what's common. So atypicals are common. You got to think about strep pneumo, which is common, and then the answer choices will just be what treats those. So the clindamycin, let's just go down the list. Clindamycin, often referred to as an anaerobe killer. It's good for those with aspiration pneumonia traditionally, although recent literature shows that maybe you don't need it for aspiration. But regardless, on the test, for the purposes of the STEP exam, if you see anaerobes or concern for aspiration, clindamycin should be on your differential as a treatment modality. Cefepime is the next answer choice. Cefepime is very broad spectrum. It's that classic med that we give when we're concerned about gram-negative frauds or specific scenarios such as febrile neutropenia. Cefepime is the answer choice. In regards to community-acquired pneumonia, it's probably too strong. Ceftriaxone and doxycycline, I think, is the correct answer. Ceftriaxone will be fantastic for your strep pneumo, and then doxycycline for your atypical. So this would be a good answer choice for your community-acquired pneumonia. And then vancomycin, piperacillin, tazobactam, again, very broad. You're basically covering MRSA, Pseudomonas, all the bad players, anaerobes. So this is not a good choice for just a common community-acquired pneumonia. This would be for hospital-acquired pneumonia or sepsis of unclear etiology. So, next question. 42-year-old male with uncontrolled HIV presents with cough and productive sputum. Your attending turns to you and asks, what bacterial pathogen is the most common cause of pneumonia in those with underlying HIV? Your response is it Mycoplasma, Pneumocystis jirovecii, Strep pneumo, or Staph aureus? So this is kind of a gotcha question. So my first question to you would be, what is the most common pathogen in the general public? In which case your answer would be Strep pneumo. And then if I extend that to HIV patients, your answer would be, again, Strep pneumo. So Strep pneumo is the most common cause of pneumonia in those with HIV. Even though Pneumocystis jirovecii is much more common in those that are immunocompromised, it still doesn't mean that it's more common than Strep pneumo. So Strep pneumo is still the correct answer here. A 3-year-old child presents lethargic to the ED. The mother states he had fevers and chills a couple days ago, for which she gave some Tylenol and some baby aspirin. He currently is without fever, but he remains lethargic, like I said. So what would you see in this child? Is the answer nuchal rigidity, Kaiser-Fleischer rings, malfunctioning chloride channels, or microvascular hepatic steatosis? So this is a tough question. So kiddo was obviously sick, fever, chills, kind of nondescript symptoms, given some Tylenol and aspirin. So first answer choice, nuchal rigidity. Not a bad answer choice. The kiddo could be having a meningitis. They could have had the fevers and chills, and now they're lethargic. I mean, honestly, nuchal rigidity, I wouldn't fault you for picking that answer choice. It's a pretty good one. I think there might be a better one, though, so let's move forward. He's currently without a fever, which might be a little rare in someone that's actively experiencing a meningitis picture. So we'll keep nuchal rigidity for now. Kaiser-Fleischer ring. So you're like, what's a Kaiser-Fleischer ring? I don't really remember. It sounds familiar from, the first 2 years of med school. But just to jog your memory, Kaiser-Fleischer rings are those rings around the iris that you find in people with Wilson syndrome where they can't get rid of their copper. So in this case, likely not so in a 3-year-old kid. So you can kind of rule that one out. Malfunctioning chloride channel. So what would you see in this child? Do they have fevers and chills because they have cystic fibrosis? I guess you could make that stretch, although I don't think they gave you enough information to confirm that. So although cystic fibrosis could be something you're considering, I don't know if it's necessarily the best answer choice. I'm sure the parents would typically know prior to the age of 3, but maybe not. And then the final answer choice, microvascular hepatic steatosis. What is the one condition where this is pathognomonic? And that would be Reye syndrome. And what is Reye syndrome? It's kind of an unclear diagnosis, but it's one that often accompanies a kiddo that had signs such as viral symptoms, so fevers and chills like this kiddo had, and then was given aspirin, which this kiddo did receive, and therefore it can cause some lethargy. It affects the brain, also affects the liver, and in the liver you can see microvascular hepatic steatosis due to all of the reactive oxygen species. So in this question, although nuchal rigidity is great, I think microvascular hepatic steatosis is trying to hit Reye syndrome and the baby aspirin and the influenza-like symptoms, so I think that's the better choice here. All right, the next question. Strep pneumo is the #1 culprit of which of the below? Sinusitis, otitis media, pneumonia, or meningitis? And you click each one that you thought was, strep pneumo was the #1 culprit. And in this case, you would click all of them. And this is just to get you back to the MOPS acronym, where meningitis, otitis media, pneumonia, and sinusitis. If you remember the sketch for strep pneumo, MOPS was one of the acronyms they use. And just to kind of remind you, strep pneumo is the most common cause of all 4 of those pathologies. All right, a couple more questions. A 24-year-old normal term female Let me repeat that. All right, a 24-day-old normal-term female is brought in by her parents due to fussiness, runny nose, and cough. Physical exam is significant for bilateral wheezing. She's in daycare, where other children have recently been sick. Proper management includes, is it antifungals, antibiotics, supportive care, or immunoglobulins? Well, we have a 24-day-old normal term. So normal term is making me think she's at least immunocompetent. She's not someone like a preemie that needs a little bit more help. She has these nondescript symptoms, don't seem too severe, just some fussiness, running nose, and cough. But on her physical exam, she has bilateral wheezing. So wheezing with URI symptoms and other kiddos have been sick makes me immediately think in this age group of virus. Often RSV, makes me think of bronchiolitis. So in that case, supportive care would be my choice, and I think that is the correct answer. Immunoglobulins is interesting. Perhaps if this was, instead of a 24-day-old normal-term female, if this was a 1-day-old preemie in the NICU, immunoglobulin regimens such as palivizumab would be the correct answer. But in this case, I think supportive care is all you need. All right, a patient with splenic lymphoma, status post-emergent splenectomy, is told he should receive certain vaccines given his recent procedure. The recommended vaccines include, so in this question you need to know, does the spleen do? What organisms does it specifically help target? And in this case, it would be encapsulated organisms. So as we go down the list, we'll just say yes or no if it's encapsulated. So Haemophilus influenzae, yes, encapsulated, so you would need a vaccine, correct. Influenza is a virus, so I'm not sure. We'll move on. Neisseria meningitis, yes, it is encapsulated, so we would want to get the vaccine for that. Serratia, not really. It's not even a bug that I think we have a vaccine for, so not a correct answer. We wouldn't check that. And strep pneumo is yes, encapsulated, and yes, we have a vaccine for that. So strep pneumo, Neisseria, and Haemophilus influenzae. And then the final answer choice, which was influenza, is also technically correct based off some guidelines I was reading. I was like, oh, you know what? Does this make sense? Everyone should get an influenza shot. So I don't know if I should put this in the answer choices, but actually there's some good research showing that people with an influenza vaccine after splenectomy have an improved mortality almost or at least by 50% compared to those that do not. So it's clear that the spleen really helps with eradication of some viral infections such as influenza, and that without it, vaccines are very important. So influenza would be a correct answer as well. All right, the next question. A 56-year-old man with a history of pancreatitis and seizures presents with left upper lobe pneumonia. He's treated appropriately and discharged. 4 months later, he presents for pneumonia again in the same place. What is the likely underlying etiology? The answer choices are poor inspiratory effort, an underlying genetic condition, bronchial obstruction, poor pulmonary blood flow. So this is a tough one. Pneumonia in the same place twice should always have you think about something that we'll get to, but let's just go down the answer choices real quick. So poor inspiratory effort, sure, maybe the person has obstructive disease, maybe the person is larger body habitus and therefore has some restrictive disease and it prevents poor inspiratory effort. Maybe that could cause atelectasis and again the same pneumonia in a similar place. So it's not a bad answer choice. We'll keep it for now. Underlying genetic condition. Someone with recurrent pneumonia's underlying genetic condition, you would think maybe cystic fibrosis, maybe something that causes multiple mutations, but nothing specific in the lung that jumps to mind. So because this guy's a 56-year-old guy, I'm not entirely sure we want to go down that route. So not the best answer choice, and honestly, I wouldn't have a genetic condition that comes to mind immediately. Bronchial obstruction, so that's interesting. They don't really say what's obstructing the bronchioles. Is it a tumor? Is it a granulomatous process? So we don't really know what, but bronchial obstruction in theory makes sense if you have poor airflow and atelectasis, and it could be a breeding ground for bacteria. And then poor pulmonary blood flow, you think about this in pulmonary emboli and chronic clots and things like that, but would it cause another pneumonia or make you more susceptible in the same exact place? Not entirely sure. Not entirely sure if the shunting mechanisms would prevent that or not. So this is kind of tough. Ultimately, I think the best answer in a patient with consistent pneumonia in the same place would be bronchial obstruction. And we have an image here. So this is a chest x-ray. It's hard to see cancer on chest x-rays. This is a pretty exaggerated picture, but basically you have air obviously coming down and then you have a cancer blocking here. So Because of that, air can get in. Sometimes it's tough to get out. You don't have good air movement around here in the lower lobe. Sorry about that. You don't have good air movement right here in the lower lobe, and because of that, it can be a nice breeding ground for bacteria and can cause a lot of issues. So bronchial obstruction is commonly the reason someone would have recurrent pneumonia in the same exact place over and over again. And then finally, the last question. Your daughter asks why you need a flu shot each and every year. Your answer is 1. Antigenic shift, 2. Pleiotropy, interesting, 3. Defects in human mismatch repair proteins, and 4. Antigenic drift. So, in our podcast, Bobby has a good, easy, clear kind of explanation as to how you can differentiate shift and drift in a fun, meaningful way. Shifts suck, so when you think about antigenic shifts, think about things that suck, and what suck are pandemics, and therefore the antigenic shift can cause pandemics. Bobby had us remember antigenic drift with the movie Tokyo Drift, Fast and Furious. They come out every year. There's always a new drift movie, and because of that, you can think of antigenic drift as something that causes point mutations that leads to new variants of influenza every year, and why you need a flu shot each and every year is likely due to this antigenic drift. So that would be the correct answer. Pleiotropy is when one gene affects multiple phenotypic traits, so that's not really related to this. And then defects in human mismatch repair protein, you can think about things like Lynch syndrome, among other things, but in this case, not the reason you need a flu shot every year. So that is it for the quiz. If you hit the submit button, you would see that the quiz would populate with the answer choices that were correct, as well as with different key explanations. So even though this quiz is only 20 questions, I would argue that probably there's 40 to 50 really good teaching points here, just with all the answer stems and all the explanations that we try to put in for y'all to make it very thorough and comprehensive. So with that being said, hope you guys found this helpful. If there's anything that you might find more helpful, send us a message, follow us on Instagram. We love discussing things with y'all. Come back here and try the other 3 practice exams. We'll make some videos for those shortly. All right, guys, have a fantastic day. Take care.